Have you ever noticed something strange happening with your hand? Maybe a lump in your palm that just sort of appeared, or maybe a finger that just won't straighten out properly, no matter how hard you try.
Yeah, that's a classic sign people mention.
It can feel a bit like your hand's developing a mind of its own, can't it? Subtly changing how you do things, making, well, simple tasks surprisingly difficult.
It really can creep up on you.
Today, we're embarking on a deep dive into a condition that affects hand function for millions, literally millions of people worldwide, yet often remains, well, widely misunderstood. Dupuytren's contracture.
That's right.
So for this deep dive, we've gathered a whole stack of your sources, articles from top medical journals, in-depth research papers, clinical notes from specialists, really good stuff. Our mission today is to take all that complex info and distill it down, get to the most important and often quite surprising insights.
Yeah, cut through the noise a bit.
Exactly. Think of it as your shortcut to being genuinely well-informed about this curious disorder. Moving beyond just the basics to really grasp the nuances that matter and, hopefully keep you hooked with some fascinating facts along the way.
And our mission for this deep dive is indeed pretty clear. We're going to pull back the curtain on Dupuytren's contracture.
Yes.
We'll explore what it actually is, fundamentally. We'll delve into the really intricate reasons why it seems to occur.
The why is always interesting.
It is. And understand how it typically presents in daily life, from those early, maybe subtle signs, right through to the more advanced stages.
Okay.
And then, critically, navigate the full spectrum of modern treatment options available today. What actually works.
Good.
And importantly, we'll also spend time on how you can empower yourself in managing the condition, even with the understanding that, well, a complete cure, at least for now, remains elusive.
Okay, let's unpack this. So, to begin, let's get right to the core. What exactly is Dupuytren's contracture? Fundamentally, it's a disorder affecting the palm of your hand and eventually your fingers. It seems to zero in on a very specific type of fibrous tissue, a connective tissue called the fascia.
That's the key target. Yeah.
Now, in a normal, healthy hand, this fascia is kind of an unsung hero, isn't it? It's like this finely woven, protective, stabilizing network.
Absolutely essential, but you never notice it when it's working properly.
Right. It covers all those crucial nerves, blood vessels, muscles, tendons, keeps them all held securely in place. And it also helps keep your skin firmly attached, positioned correctly, so your hand can move fluidly.
That's perfectly put. But in Dupuytren's disease, this perfectly normal, functional fascia undergoes a significant and, unfortunately, abnormal transformation.
Okay, so it changes.
It changes.
Yeah.
Instead of staying healthy and flexible, it begins to thicken, often quite dramatically. And as it thickens, it forms what we typically describe as tough, rope-like structures. We call them cords.
Cords, okay.
And also distinct nodules, which are more like small bumps or lumps you can feel.
Right.
Now, here's a really critical insight and a common misconception we absolutely need to clear up right away. These cords are not tendons.
Ah, that's important.
Hugely important. Many people feel these ropey things under their skin and think, oh, that must be my tendon acting up. But tendons are dynamic. They move when your muscles contract.
Right, they pull the bone.
Exactly. These Dupuytren's cords, though, they're entirely static. They don't move with your muscles. They're not connected to your active muscle system. They just sit there and contract over time.
So they're rogue structures, basically.
You could say that. They can appear as a single cord, or you might find several, sometimes separate, sometimes interconnected into this complex, almost random-looking network.
And the nodules, the bumps.
Right. You'll also typically find those nodules in the hand. They can feel quite firm. Their appearance and size might change. Sometimes they grow, sometimes they shrink, sometimes they just stay the same for ages. It's really, really individual.
I remember reading one of our sources. It had such a vivid way of describing this. The Dupuytren's palm skin, it said, was like a road. Really helps you picture it.
Oh, that's a good one. How did it go?
It said, think of the Dupuytren's palm skin like a road. Some areas are swollen and puffy like a speed bump. In other areas, the skin is puckered and pulled down like a pothole.
Wow, yeah, speed bumps and potholes.
Yeah.
That really paints a picture, doesn't it? You can almost feel it.
It really does. It's amazing how these internal changes become so visible on the surface.
It truly is. And as these cords and nodules keep growing, keep thickening, that's when the real functional impact starts to bite.
Because they pull.
They pull. They exert this strong, steady pull, drawing your fingers into a bent or flexed position towards the palm. This makes it harder and harder, and eventually often impossible, to fully straighten the affected fingers.
I've seen pictures of advanced cases. It can be quite dramatic.
Oh, absolutely. Sometimes the finger gets pulled almost completely into the palm, and that's the core problem. This physical limitation becomes profoundly bothersome, really frustrating. It significantly limits how you can use your hand for just, everyday things.
Like what?
Grasping larger objects, playing musical instruments, even just opening your palm flat to receive change or wash properly. It's about regaining that basic, unrestricted hand function.
Here's where it gets really interesting because we start peeling back the layers of why this happens, what's actually causing it.
So if we delve into the why behind Dupuytren's, well, it gets incredibly complex, fast. The exact single cause, still largely unknown. It's a bit of a medical mystery in its fundamental triggers.
Really, still.
Still. But what we do know is that it's profoundly intricate. Multiple factors, all intertwined. The primary player, though, the one that consistently stands out in all the research, genetics.
Ah, okay. Hereditary.
Very much a hereditary disease. That means your family history, your ancestry, plays a significant, maybe even dominant role in whether you develop it. You can't change your genes, obviously,
Yeah.
but knowing this helps explain a lot of the patterns we see.
And what are those patterns? Who gets it most often?
Looking at the demographics, we see some remarkably clear trends. It's significantly more common in men than in women. It typically shows up in people over the age of 40.
Okay, older men, more likely.
Generally, yes. And the ancestry link is fascinating. The research shows a very strong connection to Northern European descent.
Specifically.
Specifically, studies highlight higher prevalence in people with English, Irish, Scottish, French, Dutch, and Scandinavian backgrounds. It's a really striking demographic pattern.
Wow, very specific.
It really underscores the genetic roots. Conversely, it's quite rare in African, Middle Eastern, and most Asian populations. Interestingly, even when it does occur in Asian populations, the disease often involves the palm more than the digits themselves. A subtle difference.
That is fascinating. Beyond genetics, though, our sources connect Dupuytren's to several lifestyle factors too, right? Things that might contribute.
That's right.
Genetics isn't the whole story.
We're talking things like smoking, diabetes,
Yeah.
alcohol consumption too.
Yes, those are frequently cited associations. Also, interestingly, a lower body mass index, and perhaps less surprisingly, just the process of aging itself.
And then there are other medical conditions linked. I saw tuberculosis, chronic lung disease, HIV/AIDS, even epilepsy, and the meds for it.
Correct. That's a surprisingly broad range of associations, isn't it? It makes you wonder.
Yeah, like you have the family history and you smoke or have diabetes. Do these factors just contribute or do they actually speed things up significantly?
That's an excellent question, and it's exactly what researchers are still trying to fully pin down. The current thinking is that while the genetic predisposition is the main driver, these lifestyle factors and associated conditions likely act as, well, exacerbating influences or risk modifiers.
So they add fuel to the fire. That's a great way to put it. They probably don't cause Dupuytren's in someone without the genetic vulnerability. But if you have that genetic tendency, these factors might accelerate the onset, increase the severity, or lead to faster progression.
How?
Well, think about the microvascular changes linked to smoking or poorly controlled diabetes.
Yeah.
They could potentially create an environment in the hand tissue that's more conducive to those pathological changes we see in Dupuytren's. So yeah, not starting the fire, but maybe pouring fuel on it.
That makes sense. And speaking of clearing things up, here's a really critical insight, especially for anyone who's had a hand injury or works with their hands a lot.
Yes.
Despite what might seem intuitive or what you hear anecdotally, the research is clear. Your hard manual labor or that old injury is not the main cause of Dupuytren.
Absolutely vital to clarify this. It's a very common worry. There is no strong, consistent evidence that direct hand injuries or specific types of jobs, even repetitive strain, lead to a higher risk of developing Dupuytren's contracture.
So my typing all day isn't going to cause it.
No evidence for that. Now, there might be a mild link to trauma in someone already genetically at risk. For instance, someone might develop a single nodule after, say, a wrist fracture.
But it doesn't usually progress.
Often doesn't progress to the full contracture. It seems more like a localized reaction in someone already predisposed. Those anecdotal reports of trauma making it worse, not really backed by solid evidence. And critically, there's just no convincing proof it's caused by overuse.
That's a huge relief for many people, I imagine.
It should be. Manual laborers, people using their hands extensively, you can largely put your mind at ease about your work directly causing this. Now, if we dive a bit deeper into the biology, the pathophysiology, what's really fascinating is the cellular change that happens Normal fibroblasts, those are the cells that build and maintain our connective tissue. They undergo this profound abnormal cytokine-mediated transformation.
Okay, cytokines, those are like chemical messengers in the body, right? Tiny little text messages between cells.
Exactly. Perfect analogy. And in Dupuytren's, certain ones, TGF-beta 1, TGF-beta 2, epidermal growth factor, PDGF, connective tissue growth factor seem to send the wrong signals.
Bad texts.
Bad texts, exactly. Instead of telling fibroblasts to maintain normal tissue, they effectively tell them to turn into abnormal myofibroblasts.
Myofibroblasts. Myo like muscle.
Precisely. These myofibroblasts are key because they have these exaggerated, abnormal contractile properties. Think of them like tiny microscopic muscle cells that suddenly start pulling and tightening the tissue in an uncontrolled way.
Wow.
And technically speaking, these myofibroblasts contain intracellular actin filaments, tiny muscle fibers. They also connect to each other and the surrounding tissue via extracellular fibronectin like tiny grappling hooks.
Okay.
This network lets them link up and contract together like a steadily shrinking fishing net, pulling everything inwards. It's this uncontrolled pathological contraction that creates the cords and contractures.
So it's almost like the hand's internal support system starts shrinking the house instead of just holding it up. That's a powerful image.
It is. And this remodeling isn't just about the cells. The collagen itself changes too. That's the main protein-giving structure to connective tissue.
How does that change?
Specifically, there's an increase in the ratio of type 3 collagen compared to type 1. Think of type 1 as the strong, rigid scaffolding. Type 3 is more like the flexible, wound-healing type. In Dupuytren's, you get too much type 3, contributing to the stiffness and persistent contraction of the cords. It's this whole complex biochemical cascade.
But that's a lot of intricate biology happening under the skin. So what does this all mean when it comes to predicting how bad it might get or how likely it is to come back after treatment?
That's a critical question. For someone diagnosed, what suggests their disease might be more aggressive or more prone to recurrence?
Exactly.
Well, our sources highlight some really important risk factors for increased severity and recurrence. These include being male, having the disease start before age 50, relatively young onset, experiencing it in both hands, what we call bilateral disease, which implies a stronger systemic element, and having a strong family history, where maybe a sibling or parent also has it quite significantly.
So those are red flags for a tougher course.
They are. They all point towards what we call a more aggressive form, or Dupuytren's diathesis, making it crucial for prognosis. If you tick several of those boxes, your disease might be more challenging to manage long-term.
Right. So moving on to living with it. For most people, the journey starts with what you can actually see and feel on your hand, doesn't it? Walk us through those typical first signs.
Usually, the very first things people notice are lumps or nodules, and then later these bands or cords developing, typically on the palm side of the hand.
And what do they feel like?
The lumps are usually quite firm, almost stony, and they feel like they're stuck right to the skin. And the skin above them can look a bit thickened or puckered, giving it that pothole appearance you mentioned from the road analogy.
Ah, yes, the potholes.
The progression often follows a pattern. Nodules appear first. Sometimes, initially, they might be a bit tender or sensitive.
Oh, so they can be painful at first.
They can be, yes. But that tenderness usually fades over time as the nodule matures. Then, these nodules often thicken and extend into those dense, tough cords we've discussed, running along the lines of your tendons.
And that's when the bending starts.
Exactly. As this fibrous tissue tightens, that's when the contractures begin. Your fingers start to get pulled towards the palm, making it harder and harder to straighten them fully, or even to spread them apart.
Which fingers are most commonly affected?
The ring finger and the little finger are, by far, the most common culprits. But really, any or all fingers, even the thumb, can be involved. And each hand can be affected differently, different patterns, different timing. It's very individual.
A unique fingerprint of the disease, as you said. And what about the joint specifically? Does it affect all the finger joints equally?
That's a good distinction. The metacarpophalangeal joint, the MCP joint, your main knuckle where the finger meets the hand that's the most commonly affected, often the first to show contracture.
Okay, the big knuckle.
Right. Next is the proximal interphalangeal joint, the PIP joint, the middle joint of your finger. Contractures there are often harder to treat and more likely to recur than MCP ones because the anatomy around it is more complex.
Harder to fix, okay.
And finally, the distal interphalangeal joint, the DIP joint, closest to your fingernail, that one's least likely to be involved in Dupuytren's. So tends to progress from the palm outwards, affecting the joints closest first.
And this inability to straighten a finger, it sounds simple, but I imagine the daily impact is huge. How much does it really affect someone's life? Shaking hands, putting on gloves.
Oh, absolutely. The inability to fully extend fingers impacts daily activities, sometimes in ways you wouldn't even think of. That Houston's tabletop test we mentioned is very telling.
Remind us what that is.
It's simply trying to flatten your hand completely on a surface, like a table. If you can't get your palm flat because a finger is contracted, that's a positive test and a strong sign of significant contracture.
Easy check.
Very easy. Beyond that, the challenges range from simple things like washing your hands properly or getting gloves on, to holding larger objects, a steering wheel, a water bottle, or getting your hands easily into pockets.
And shaking hands must be awkward.
It can be, especially if it's your dominant hand. For hobbyists, it impacts playing instruments, gardening, some sports. These minor limitations really add up and can significantly affect quality of life and independence.
What seems particularly challenging is its unpredictable nature. You said it's really difficult to predict how it will progress for any one person.
That's absolutely right. It's a complete spectrum. Some people might only ever have small, relatively soft lumps in their palm that cause minimal bother. Others, unfortunately, develop rapidly progressing, severely bent fingers that really impede hand function. There's no single pathway.
Yeah.
And this brings us back to that concept of Dupuytren's diathesis. That term signifies a more severe, aggressive form of the disease.
The one linked to those risk factors like early onset and family history.
Exactly. Diathesis is characterized by early onset, before 50, being more common in white men, having both hands involved, a strong family history, and crucially, these ectopic manifestations.
Ectopic meaning outside the hand.
Precisely. The disease appearing in locations outside of the palm, which signals a more systemic, widespread genetic issue, is at play.
What kind of locations are we talking about?
Well, first, there's Lederhosen disease. That's lumps and cords on the soles of the feet. Occurs in about 10 to 30% of Dupuytren's cases.
He too, wow.
Then there's Peyronie's disease, which affects the genital location in men, seen in about 2 to 8% of cases.
Okay.
And finally, knuckle pads, also known as Gerhard's pads. These are thickenings on top of the knuckles on the back of the hand, quite common, maybe 40 to 50% of cases. They can sometimes be tender, but rarely cause functional problems themselves.
So finding these things elsewhere strongly suggests that more aggressive diathesis.
It confirms it, yes. It means the underlying genetic predisposition is more widespread. And, for those really interested in the nitty-gritty, especially surgeons, understanding exactly where these cords form is critical. Orthobullets goes into detail here.
Give us a couple of examples.
Sure. The pratinus cord is usually the most proximal one in the palm. It often forms a central cord, causing that MCP joint contracture. Importantly, it's usually not tangled up with the nerves and blood vessels.
Safer to deal with, maybe?
Relatively speaking, yes. But then you have the spiral cord. This one's key, especially for PIP joint contractures. It's tricky because it travels under the neurovascular bundle.
Under the nerves and vessels.
Yes. And as it tightens, it pulls that bundle, displaces it centrally, and makes it more superficial. This puts the nerve and vessel at risk during surgical resection. Careful dissection is absolutely crucial.
Are there clues a surgeon looks for?
Yes. The sources mention predictors. A PIP joint flexion contracture itself is a strong predictor, 77% positive predictive value. An interdigital soft tissue mass, a lump between the fingers, is another, 71% positive predictive value.
Okay, important surgical clues. Any others?
There's the retrovascular cord, running behind the neurovascular bundle further down, causing DIP contracture near the nail, and the natatory cord, causing web space contracture, limiting finger spread. It's also useful to know what's not involved. Cleland's ligament and the transverse ligament of the palmar aponeurosis are generally spared. These details matter hugely for treatment planning.
Wow, that's incredibly specific. Understanding those internal changes really makes you wonder. How does a doctor officially diagnose this? What do they look for?
Well, diagnosing Dupuytren's is primarily clinical. It relies heavily on 2 things. A careful history, what you've noticed, when it started, how it's progressing, and a thorough physical examination of your hand.
What happens in the exam?
The doctor will meticulously note the exact location of any nodules or cords. They'll measure your finger's range of motion, especially focusing on how much you can straighten them. That deficit is key. They'll test sensation to check for nerve involvement. Sometimes clinical photos are taken, especially to track changes over time.
And the tabletop test?
Yes. Houston's tabletop test is a key part of the exam. If you can't flatten your palm completely, that's a positive result, indicating a functionally limiting contracture.
Any other signs they look for?
Definitely. Finding a nodule beyond the main knuckle, the MCP joint, is a strong clue for that tricky spiral cord potentially displacing the digital nerve. They'll also actively look for involvement in both hands, and any of those ectopic signs, feet, knuckles, as that signals the more aggressive Dupuytren's diathesis.
What about imaging? X-rays, MRIs?
Interestingly, our sources are quite clear. X-rays, ultrasounds, or MRIs are generally unnecessary for diagnosis of Dupuytren's itself.
So you probably won't get a scan just for this.
Probably not. A doctor might order imaging, but usually it's to evaluate other kinds of hand masses or rule out different causes for joint stiffness, like arthritis or maybe a bone issue that's mimicking the symptoms.
Could ultrasound see it, though?
It can, yes. Ultrasound can show the thickened fascia and nodules, giving visual confirmation. But it's not typically needed for the primary diagnosis. The clinical exam is usually enough.
And it's important to know what else it could be, right? Things that might look similar?
Absolutely. Differential diagnosis is crucial. For instance, a locked trigger finger also causes a bent finger, but it's usually painful when you try to straighten it, with specific tenderness at the A1 pulley.
Okay, what else?
Pulley rupture with bowstringing, often linked to trauma where the tendon lifts away. Intrinsic minus, or claw hand from ulnar nerve palsy that has specific joint patterns and sensation loss. And Volkmann's contracture, usually after compartment syndrome, has a very characteristic wrist and hand deformity. Ruling these out ensures the diagnosis is correct. So let's pivot now to navigating the treatment options. And it's really important to set realistic expectations right from the start.
Okay. What should people know?
Currently, there is no definitive cure for Dupuytren's contracture. The underlying genetic tendency remains. However, it's generally not life-threatening or even limb-threatening. And importantly, it's not cancer. It won't spread elsewhere.
That's reassuring.
It is. The main goal of any treatment, surgical or non-surgical, is to improve finger motion and overall hand function. Complete correction isn't always possible, especially with severe, long-standing contractures, and the disease can recur.
So when is treatment usually recommended?
Typically, when the contracture stops you from laying your hand flat on a table, that functional benchmark, or when it significantly interferes with daily activities. A hand surgeon could be orthopedic, plastic, or general surgeon with hand specialization decides the best approach based on the stage, pattern, and your individual needs.
Okay, managing a chronic condition, not necessarily curing it. Let's dive into the non-surgical paths first. What about mild cases?
For the mildest cases, often the first step is simply observation only. If you just have nodules or very mild contractures causing no functional problems, just watching and waiting might be best.
If it ain't broke.
Exactly. Hand therapy can also be helpful, especially for mild cases or minor contractures. Now, traditional splinting or stretching usually doesn't prevent worsening, but it's safe to try and might delay progression or improve PP joint flexion a bit, particularly after a procedure.
What does hand therapy involve?
Things like paraffin wax treatments, managing scar tissue and swelling, dynamic or static splinting, maybe specialized treatments like phonophoresis or iontophoresis to help deliver medication locally. It's about managing symptoms and function.
What about injections? I've heard of steroid injections. Are they used here?
Yes, corticosteroid injections are an option, but with a specific target: painful nodules.
Just for pain?
Primarily, yes. The injection helps reduce that localized pain and inflammation. But, and this is crucial, it's not a cure for the underlying disease. It's not likely to stop cords forming or the condition worsening.
Does the pain come back?
It can. Up to a 50% recurrence rate is reported. And there are potential side effects. Fat atrophy under the skin, pigment changes, very rarely tendon rupture.
Yeah.
So it's a tool for managing painful nodules, not modifying the disease itself.
Okay, so that's more of a temporary fix. What about something that actually tackles the cord itself but without major surgery?
Right, moving to more targeted non-surgical options, we have collagenase injection, specifically collagenase clostridium histolyticum, or CCH. This is quite fascinating stuff.
How does it work?
It's an enzyme derived from bacteria, Clostridium histolyticum. It selectively targets and breaks down type I and type 3 collagen, the problematic types in Dupuytren's cords. Crucially, it has low activity against type VV collagen, which is found in blood vessels and nerves.
Ah, so it's targeted, less risk to nerves.
Exactly. That selectivity explains its relatively low neurovascular complication rate. It's good at dissolving the cord without damaging vital nearby structures.
What's the procedure like?
It's typically a two-step process.
Yeah.
First visit, the cord is injected with the medication. usually 0.58 milligrams per cord, up to 2 joints or cords per hand per visit. Afterwards, expect some swelling, bruising, maybe pain, manageable with a bulky dressing, elevation, maybe some acetaminophen or NSAIDs.
And step 2.
Second visit, usually 1 and 3 days later. After numbing the hand, the physician manually stretches and straightens the finger to physically rupture the cord that the enzyme weakened. Patients often feel a distinct pop.
A pop. Sounds dramatic. Does it work well?
It can significantly improve motion, yes, reduce the contracture angle quite effectively. But it doesn't fully remove the cord, just breaks it. Recovery is pretty quick, days to a few weeks. You can often use your hand lightly almost right away once swelling goes down.
What about recurrence? Does it come back?
Recurrence is definitely a factor. Roughly 1/3, maybe up to 50%, see the cord return within 5 years. That's generally higher than with surgery. It's also more successful for MCP joints than PIP joints. And when PIPs recur after CCH, they can be more severe.
So summing up CCH, pros and cons, who's it good for?
Pros: office procedure, patients awake, less invasive than surgery, often less pain swelling initially. Great for patients with significant medical issues who might not tolerate surgery well. Cost can be a factor. Only 2 cords per visit. Recurrence rate is higher than surgery. Complications are usually minor swelling, bruising, pain, skin tears, about 12% higher with age-more correction. Major ones like tendon rupture or nerve injury are rare, about 1%.
Okay. Is there another minimally invasive option? I think I read about needling.
Yes, needle aponeurotomy, or PNA, sometimes just called needling or percutaneous needle fasciotomy. Also done in office, local anesthetic. Instead of an enzyme, a small, sharp needle is used to repeatedly puncture and cut the cord under the skin in several places.
Just physically cutting it with a needle?
Essentially, yes, weakening it. Then the physician stretches the hand to break the weakened cord and straighten the finger. Again, the cord tissue isn't removed, just disrupted.
Recovery time.
Remarkably quick, often just a few days. Very appealing for some.
Recurrence, similar to CCH.
Yes, recurrence is similar, maybe around 33% to 58% within 3 years, higher than surgery. Also more successful for MCP than PIP contractures.
Complications.
Generally rare. Infection maybe 1.1%. Nerve or blood vessel injury around 2-3% in primary cases, but, and this is important, that risk can jump up to 20% in recurrent cases, especially if those spiral cords have displaced the nerves. Also potential for pain and stiffness. So convenient, quick recovery, but maybe less durable long-term than surgery for some.
That's a really clear picture of the non-surgical side, but sometimes you need more direct intervention, right? When does surgery become the recommendation?
That's a crucial decision point. Surgery is usually recommended when the contracture significantly interferes with hand function. Failing the tabletop test is a good indicator, or for specific measurements like MCP flexion over 30 degrees or any troublesome PIP flexion. Remember, painful nodules alone aren't a reason for surgery. It's about restoring function lost to the contracture.
And the goal of surgery, is it a cure?
The goal is to reduce the contracture, improve motion and function. As we've said, no known cure, but surgery aims to set back the clock by removing or releasing the limiting cords. The tissues can still develop new cords later, but the functional gains can be significant and last for years.
How's it usually done? Anesthesia? Inpatient?
Can be local, regional block, or general anesthesia. Almost always outpatient, same-day surgery. You go home afterwards. Now, there are several types of surgical procedures. The simplest is a fasciotomy. Here, the cord is just cut with a small knife or needle, but not removed. Less invasive, smaller cuts.
But the diseased tissue stays.
Exactly. So the potential downside is a possibly higher recurrence rate than procedures that remove the tissue. Often the wound is left open to heal gradually, which can reduce hematoma risk, but means longer wound care. Then there's partial palmar fasciectomy, also called regional or segmental fasciectomy. This is the most widely used surgical treatment.
What happens here?
The surgeon makes an incision, often zigzag to help skin healing, and carefully removes as much of the abnormal tissue, the cords, maybe even diseased skin as possible.
So it's more thorough removal. Advantage.
The main advantage is removing the diseased tissue, which should, in theory, lower the recurrence risk compared to just cutting the cord. Healthy overlying skin is usually saved unless it's really involved.
How are the wounds closed after this bigger procedure?
Usually stitched, but sometimes parts are intentionally left open, the McCash technique, to reduce blood collection and stiffness, though it means longer healing time. If lots of skin is removed, especially in recurrent cases, skin grafts might be needed, often taken from the upper arm.
Outcomes. Does it work well?
Generally, yes. Significantly improves finger straightening and function. Recurrence rates vary, but typically lower than non-surgical options, maybe 3.5% to 20% at 4 years. Those studies differ on definitions. So good
Cool.
chance of long-term improvement. Going further, there's total or radical palmar fasciectomy. This is much more extensive, removing all palmar and digital fascia, even the seemingly healthy stuff.
When would that be done?
Rarely needed for initial cases. Usually reserved for very severe, widespread disease, multiple joints involved, or tough recurrences. But the cons are a high complication rate and often, surprisingly, little extra benefit in preventing recurrence. So it's not used very often. And finally, for really chronic, recurrent, advanced cases, there are salvage techniques.
Like what?
Dermofasciectomy, removing the cord and the overlying skin. Requires skin grafting, but helps prevent recurrence under the graft. In really severe, intractable situations, arthrodesis, joint fusion, or even amputation of a severely contracted non-functional finger might be considered as a last resort for overall hand function and pain relief. Definitely extreme, but sometimes necessary.
It's incredible the range of options, even for severe cases. I also read about something called the digit widget. What's that?
Ah, yes, the digit widget. That's an interesting external device, usually for very severe, stiff PIP joint contractures, those middle joints that are hard to fix.
How does it work?
It's applied in the operating room, usually, and it gradually stretches the contracted finger and cords over about 6 weeks before the main surgery.
Stretching before surgery.
Exactly. The idea is this pre-stretching loosens everything up, making the later surgery, usually a partial fasciectomy, easier, safer by reducing tension on nerves and vessels, and potentially more effective at getting a full correction. It's like priming the hand for a better outcome in tough cases.
Okay, so treatment's done, injection, needling, surgery. The road to recovery then starts. What does that immediate post-treatment phase look like?
Right after surgery, your hand will usually be in a bulky dressing, protection, and compression. Crucially, you need to keep the hand elevated diligently, ideally above heart level, to manage swelling and pain. That's really important.
When do stitches come out?
Usually within 10 to 14 days, and that's often when the real work of rehab begins. Absolutely. Rehabilitation is critical. Occupational therapy, OT, or physical therapy, PT, usually called hand therapy, often starts just 3 to 5 days post-surgery. It can last 1 to 3 months, sometimes longer, depending on the case.
What are the goals of therapy?
It's multifaceted, improving strength and function, teaching scar massage techniques to keep the scar pliable, reducing swelling, desensitizing any sensitive spots, and guiding you through very specific, tailored exercises to maximize your range of motion. Splinting is also a big part of post-treatment. After surgery, you'll likely get a custom-made thermoplastic splint, often just for nighttime wear,
For how long?
often for 4 or 6 months. Its job is to protect the surgical site, prevent the scar from contracting as it heals, and maintain that newly gained finger extension. It doesn't prevent recurrence of the disease itself, but it's vital for a good recovery outcome. Splinting might also be used after CCH or needling to help keep things straight initially.
And the recovery timeline for surgery sounds like it takes a while. You said 6 to 12 weeks for function, maybe?
That's a reasonable time frame, yes. You can usually use the hand for light tasks, eating, writing, typing fairly early on, but full, strong function takes time. And what's absolutely vital, as our sources stress, is early activity.
You have to get moving.
You have to. The more you do, appropriately, soon after surgery, the better the final result. Delaying therapy, being too passive, can lead to significant stiffness. You might even lose the ability to bend the fingers properly, which defeats the purpose. Active engagement is key.
So what kind of exercises are we talking about? Can you give some examples?
Sure, it's usually staged. Stage 1, the initial weeks, wear the splint continuously, but take it off hourly for gentle exercises. Things like finger curls into the palm, hold 5s, repeat 5x, then straighten, hold 5s. Keep elevating the arm, bend, straighten the elbow regularly, and meticulous infection prevention, hand washing, clean environment, avoid risky contacts, no guarding or dusty work. Stop if the splint hurts badly and call your therapist. Then stage 2, once things start healing, maybe splint only at night, perform prescribed exercises every few hours. Morning exercises in warm water, if wound healed, with a soft sponge can be great squeeze, flatten, press with thumb, wrist lifts, gentle fluid movements.
What about specific finger stretches?
Yes, blocked extension exercises are crucial. You use your other hand to stabilize the finger below a joint, then bend only the joint above it, top joint, then middle joint, holding for 5–10 seconds. Repeat for each finger. Then bend the bottom joints while keeping the top 2 straight. Isolating the movement is key.
And regaining strength.
Fist formation is important. Make a full fist, Press fingers into it with the other hand, squeeze hard, 5 10s, then tense the forearm muscles for another 5s. After exercises, firmly massage non-scented cream into the scar, helps remodel it, reduces sensitivity.
Any other useful ones?
Tendon gliding exercises, finger walking, spreading fingers on a surface, maybe rolling a small ball between fingers. Driving. Check with insurance. Resume only when you feel safe and strong enough. And always, if an exercise causes sharp pain, stop and consult your therapist. Don't push through bad pain.
That sounds like a very involved recovery process, a real commitment. Now, with any procedure, there are risks. What potential complications should people be aware of?
That's important, yes. Complications are generally more common with more severe disease, more fingers treated, or if you have other health issues like diabetes. General risks include pain, should decrease but can persist, scarring, inevitable but manageable, and stiffness, hence the therapy.
What about nerve issues?
Loss of sensation can happen, often temporary if nerves were stretched, but usually resolves. Wound infection risk is around 7% for fasciectomy, lower for non-surgical. Nerve or blood vessel injury is more serious, 2–3% in primary surgery, but again, up to 20% in recurrent cases, especially with those spiral cords.
Any other specific ones?
Wound healing problems occur in maybe 23% of cases, higher with poor nutrition or big surgeries. Incisional scar pain affects about 17%. CRPS, complex regional pain syndrome, that chronic pain condition, maybe 5.8%, higher in females' extensive surgery. Hematoma, blood collection, about 2.1%. Skin tearing with CCH manipulation, around 12%. And a post-op flare reaction, pain, swelling, stiffness, in about 3.5%, but usually settles. And then the big one we keep mentioning, recurrence. It's a major factor. Incidence varies hugely by treatment. CCH around 50% at 5 years. PNA maybe 50% at 3 years. Fasciectomy generally lower, 3.5% to 20% at 4 years, but numbers vary.
And PIP joints are tougher.
Yes, those middle joints are harder to treat and more prone to recurrence due to secondary structures involved. Risk factors for higher recurrence include non-operative treatment, having that Dupuytren's diathesis, PIP disease itself, and small finger contracture. If it recurs badly, revision surgery might be needed, often more complex than the first time. It's often an ongoing management situation.
What's truly fascinating here, though, and quite empowering, is how much you can potentially do for yourself, too, even with strong genetics and complex treatments.
Absolutely. While there's no magic bullet cure, incorporating certain home care and lifestyle adjustments can really complement professional treatment. They might not stop the disease, but they could potentially slow progression, help manage symptoms, and just give you a better sense of control day to day.
So what kind of things are we talking about?
First, think about relieving palm pressure. Since it often starts there, consciously try to use lighter pressure when gripping things. When handling tools, gardening, anything requiring a firm grip, consider padded gloves or cushioning material like tape around handles, just minimizing that repetitive high-pressure force.
Makes sense. What about exercises at home?
Incorporating specific exercises can be beneficial, especially early on, before contractures get bad. They help maintain flexibility. Simple things like finger lifts palm flat on a table. Lift each finger individually. Finger spreads, gently spread fingers apart, then bring together. Palm raises fingers flat, just lift lower the palm.
Any others?
A hand press palms together like prayer, gently push. Finger bends just the first 2 joints, then straighten. Crucially, avoid overstretching. If a contracture exists, gently use the other hand to push affected fingers straight, just for a few seconds, only to a comfortable point. Do these multiple times daily, and practice gripping soft things like a towel to maintain dexterity without excessive pressure.
And massage, could that help?
Massage therapy is worth exploring. Gently massage the whole hand, palm, fingers with your unaffected hand, or get help. Gentle pressure, starting at the thickened tissue, moving towards fingers. Probably more effective in early stages. You could combine it with heat or use oil lotions, maybe ones with anti-inflammatory ingredients like arnica.
Diet also came up in the sources, especially the link with diabetes.
Yes, adopting a nutritious diet is emphasized, especially if you have diabetes, found in about 5% of those affected. While diet won't cure Dupuytren's, healthy eating supports overall health, might reduce systemic inflammation. Focus on portion sizes, whole fresh foods, fresh veg fruit over canned, whole grains, limit fat, low-fat dairy, lean meats like turkey, chicken, fish.
Anti-inflammatory foods.
Good idea. Green leafy veg, fatty fish, omega-3s, colorful fruits, nuts. Minimize processed foods, high salt, artificial sweeteners, additives, just generally reducing the inflammatory load on your body.
And 2 big lifestyle factors kept coming up: smoking and alcohol.
Critically important. Smoking is significantly associated with Dupuytren's, possibly via microvascular impairment affecting tiny blood vessels. Quitting early is crucial, not just for Dupuytren's, but for countless other health benefits.
And alcohol.
Heavy alcohol consumption is also linked to increased risk. Moderating intake helps manage this risk and prevents other health issues. Quitting smoking or cutting back significantly on alcohol can be tough. Support might be needed, but the potential benefits are huge.
Lastly, supplements. Anything there?
Under your doctor's guidance, maybe. Effectiveness is debated, research ongoing, but certain supplements with anti-inflammatory or antioxidant properties might help symptoms or tissue health. Again, talk to your doctor first.
Which ones are mentioned?
Things like vitamin E, antioxidant, zinc, immune support, wound healing, magnesium linked to diabetes risk if low, and turmeric, well-known anti-inflammatory spice, often taken concentrated. But definitely consult your doctor before starting anything new.
What an incredible journey through Dupuytren's contracture, from its mysterious genetic roots and that bizarre fascial transformation, through the surprising array of treatments, surgical and non-surgical, and finally those empowering self-care strategies. It's clearly a complex condition needing a multifaceted, personal approach.
Indeed. And while there may not be that definitive cure yet, our deep dive shows that early recognition, understanding your options, and getting tailored treatment can lead to really significant improvements in hand function and quality of life. The best outcomes often come from addressing concerns proactively. So consulting a hand surgeon sooner rather than later if you have concerns is definitely beneficial.
And as we wrap up, maybe consider this. Conditions like Dupuytren's really highlight the intricate, often hidden connections within our bodies, don't they? Where seemingly small physical changes can signal something deeper. It makes you wonder what other subtle shifts in your own body might be silently signaling deeper but manageable health insights just waiting for you to notice. Thank you so much for joining us on this deep dive.